Good evening, friends. Today we will discuss about strabismus. This is the second lecture of strabismus. In the first lecture, we have discussed about the introduction of strabismus and extraocular muscles. So, in this lecture, we'll dwell in how to evaluate a patient of strabismus, and we'll also briefly touch upon the treatment of strabismus. So, let me share a screen with you with a PowerPoint of uh, strabismus. Okay. So this all this anatomy we have discussed in the last lecture. Yeah. So why should we treat strabismus, friends? Because what is the need of treatment in strabismus? In certain cultures, a person who is having squint is considered to be lucky or auspicious or rich. But we must treat the squint. So what are the reasons why do we treat the squint? The first reason is everybody wants to have a binocular vision. Everybody wants to perceive a depth of an object which he sees, and that is only possible when there is binocular vision. And for binocular vision, both eyes must be aligned perfectly, and then only we can get a three-dimensional vision or stereopsis or depth perception. So if we want to restore stereopsis, we must treat squint in situations like sports or surgery. We definitely require good stereopsis. Then second thing is amblyopia. Friends, squint causes amblyopia. Squint is an important cause of amblyopia. So if we want to rectify amblyopia caused by squint, definitely we have to treat the squint. So what is amblyopia? Basically, amblyopia में क्या होता है? There is no abnormality in the eyes. The retina is normal, the anterior segment is normal. Still, the person is not able to see from that eye because of some reasons. And this is called as laziness of the eye or lazy eye. So what is amblyopia? Amblyopia is the unilateral or bilateral decrease of vision caused by form vision deprivation or abnormal binocular interaction for which there is no obvious cause found by physical examination of the eye. So this abnormal binocular interaction is the key word for strabismic amblyopia. Means amblyopia caused by squint is because of abnormal binocular interaction, while form vision deprivation is caused by other factors like uniocular refractive error or uniocular cataract. So what are the main types of amblyopia? One is strabismic amblyopia, which results from abnormal binocular interaction when there is continued monocular suppression of the deviating eye. For example, if the right eye is deviating continuously, then the image from the right eye will be suppressed in the brain, and that will cause amblyopia in the right eye. And even if the patient fixes with the right eye, still the vision is not good. That is the importance of amblyopia. That is called as amblyopia. Whereas suppression is temporary. If the patient fixes with the squinting eye and if he is able to see clearly, then he is not having amblyopia, he is having suppression. Then anisometropic amblyopia is caused by difference in the refractive error. It results from abnormal binocular interaction from superimposed of a focused and unfocused image, or a superimposition of large and small image. For example, if the patient has got -9 refractive error in one eye and he is emmetropic in the other eye, the image size will be different. The image size from the myopic eye will be smaller, and that's why the brain gets confused and the brain tries to suppress the abnormal image. Or sometimes if the image from the eye myopic eye will not be focused on the retina properly, it will be unfocused image. So this image gets suppressed in the brain. So that's why it causes amblyopia. So it is called as anisometropic amblyopia. Friends, all the anisometropias don't cause amblyopia. There has to be significant difference between two eyes to cause amblyopia. The difference is usually above plus or -3 diopters. Then deprivation amblyopia is because of visual deprivation of the one eye. Suppose a child develops cataract in one eye, then the light rays will not be able to pass through the cataract on the retina, and there will be blurred image in that eye. Unfortunately, in the amblyopygenic age, if cataract occurs, that is before 6 years of age, then this message is this image is permanently suppressed in the retina and it causes amblyopia. Then we also need to learn an important concept that is called as confusion and diplopia. So what is confusion? Confusion is nothing but simultaneous appreciation of two dissimilar images caused by stimulation of different corresponding points by different images of different objects. For example, what I want to say is, if there is a large squint, so agar right eye mein there is a big squint, then the image will be, so if there is sorry for disruption. So if there is a large angle squint, then right eye will see a different thing and the left eye will see a different thing. So it will cause confusion in the brain. While what is diplopia? Diplopia means a person will see two images of the same object. So that is called as diplopia. So it results from failure to maintain binocular vision. So this diagram shows very clearly what is confusion and what is diplopia. So here there are two different images. The right eye is looking at this red image and the left eye is looking at this black triangle. So that's why there is confusion. Whereas both eyes are looking at the same image. This is this red dot, but red dot is this red dot is perceived differently by the two eyes, causing diplopia. Then most important is appearance. If everybody likes to have beautiful straight eyes, so if for cosmetic reasons also we treat squint. So when a person of squint comes to you, uh, as with the other diseases, we have to take a very methodic history, starting from the age of onset, then which eye is affected, and whether it is the same eye or if both eyes are affected, and what is the deviation. We can ask the patient, right आँख कहाँ घूमती है, right की तरफ घूमती है, left की तरफ घूमती है. That patient whether he is having double vision, and how is the mode of onset, whether it is sudden, gradual, and what are the precipitating factors, and what are the types of deviation. It is constant or intermittent. In initial stages of squint, the patient, or in latent squint, the patient may have photophobia or asthenopia, means strain on the eyes. And as with any other disease, we have to ask whether any surgery was performed in the past for the same thing, or whether the patient is using glasses, or whether any occlusion therapy or prisms or drops were given. Family history also we have to ask, and we have to ask the birth history, and whether there was any problem in the birth. In acute cases, we can always ask the history of trauma, convulsions, or high grade of fever, or any disease that is affecting the CNS, any trauma that is affecting CNS, like viral meningitis or any space occupying lesion in the brain. So we have to ask the history of these things. And again, we have to ask birth, and we have to document the birth and medical history. So the examination of squint is a very exhaustive examination, starting from visual acuity to the sensory test. So we'll deal it one by one. So in normal patients, in adult patients, or in school-going children, we can easily measure the visual acuity by Snellen chart. But in infants, how do we measure it? So there is one test that is called as fixation preferential test, or it is also called as CSSM method, that is central steady maintained fixation. It is very simple and logical test. What we have to do is we have to take a pointed object, we have to take a bright object like a toy, red colored attractive toy to the patient and to the bachu or the child, and we have to see whether the baby is following that object with his or her eyes. That's a very simple test. If he is following the object, then it might mean that she is seeing that object. It might imply that she is seeing the object with that her eyes. Then second thing is, then first we have to do this test. Then what we have to do is we have to occlude one eye, and if the baby is resisting occlusion, that means that the other eye the vision is less. For example, in this photograph,
the examiner is occluding the right eye. So if I am occluding the right eye and the left, then the baby starts crying. That means that the left eye is having some problem in the vision, and the fixation has to be central, steady, and maintained. Means if I am putting some object in front of the patient's eyes, the baby's eyes, she has to fixate it like this. The fixation has to be central, steady, and maintained. Means maintain means even if we are occluding one eye, the other eye should be able to maintain the fixation. So these are the this is very simple test to see whether the child has got normal vision or not. Then how to test eye movements? It's very exhaustive topic, friends. But there are two types of eye movements basically. One is called as uniocular eye movements, and second is called as binocular eye movements. So uniocular eye movements are called as ductions, and binocular eye movements are vergence and vergences. Vergence means movement of both eyes in the same direction, that is conjugate movements, and vergences means movement of both eyes in opposing direction. So these are ductions. Let us not discuss ductions in detail. So let us discuss binocular movement, that is vergence. What is vergence? Vergence is nothing but binocular simultaneous conjugate movements in the same direction. The both eyes are open, and we have to attempt we have to make the patient attempt to fixate a moving target. And what is vergence? So these are types of version. Dextroversion. Dextroversion means movement of both eyes towards right. So this is dextroversion, in which what we are seeing is that this right eye is moving towards right, and left eye is also moving towards right. So right eye is abducting and the left eye is adducting. So this is called as dextroversion. Similarly, this is levoversion. Then there is elevation, then there is depression, then there is dextro elevation, dextro depression. So unfortunately the picture is not very clear, but dextro elevation means movement towards upwards and towards right, and dextro depression means downward movement towards down and right. Levo elevation means movement towards left and up, and levo depression means movement towards left and down. But in opposition to vergence, vergences are disjugate movements, means both eyes will move in opposite direction. For example, in convergence, both eyes will move centrally. Suppose अगर आप आँख के सामने पेन लेके आते हो तो दोनों eyes अंदर की तरफ मूव करेगी. They will adduct, both eyes would adduct. So that is called as convergence. Similarly, divergence is outward movement from convergent position. So if I am bringing a pencil towards a patient's eyes and I am asking the patient to look at the pencil, then both eyes will move medially. So that is called as convergence. अगर मैं पेंसिल को दूर लेके जाता हूँ, then both eyes will move in opposite direction. That is called as divergence. So how to examine the eye movements? The patient and examiner must be positioned at the same level. Then any abnormality in head position must be corrected. You have to sit in front of the patient. You have to remove any glasses, and then you have to use a pen light. And at a distance of 40 centimeter, you shine on the forehead, and then you move the light towards all the directions, towards right, then right and up, right and down, then left, left and up, and left and down. So this will test all the binocular movements. I have already discussed you which muscles are causing which movement, so I'm not going to discuss here again. So when adduction is normal, when the temporal limbus touches the inner lateral canthus, while adduction is normal when nasal 1/3 of cornea crosses the nasal punctum. And so this is how you see whether adduction and abduction are normal. Then most important test to detect squint, presence of squint, is called as Hirschberg's test. So what do we do in Hirschberg test basically? It's a very simple test. Again, the coaxiality has to be maintained. Means patient and you should sit at the same eye level, same level, and you shine a torch light on the patient's forehead. Patient के forehead पे glabella पे we have to shine a light, and we have to see a light. We will see a reflex in the patient's eyes. So this reflex is called as Hirschberg's reflex, and normally it should be in the center of the pupil. But if it is not in the center of the pupil, then the patient has squint. So This is the normal Hirschberg reflex where the torchlight is in center or slightly nasally दिखता है. And this in this left eye you can see that the Hirschberg reflex is at the pupillary edge. So the patient is having outward deviation, that is so inward deviation, that is called esotropia. In this patient, HB reflex has moved further towards right, further towards left, means it is in between the pupillary margin and the limbus. So the deviation is more. And in gross deviation, you can see that the Hirschberg reflex is at the limbus. So this is very simple test which you can do yourself. So in this patient, see, I am shining light here on the glabella and I am observing the light reflex. In the right eye, the light reflex is at the center, where in the left eye, you can see the light reflex is at the pupillary edge. So the patient is having esotropia, means convergent squint. Here again, the right eye, the reflex is in the center, and the left eye, the reflex is at the pupillary edge. It's a very gross deviation. You can see that the HB reflex in the right eye is almost at the limbus. So it is the patient is having gross outward deviation or exotropia. You can make out whether the patient has got convergent squint or divergent squint also with this reflex. Here the reflex is down and at the pupillary edge. So the patient has got vertical deviation. Yes. You carefully observe the left eye. In the left eye, the reflex is in the center, whereas in the right eye, the reflex is at the pupillary edge and slightly up. So there is some component of a downward deviation also. So this is a very curious patient. If you see the patient, you will feel that the patient is having convergent squint. His eyes are looking so much towards the nose. But if you carefully see the HB reflex, the HB reflex is normal. The HB reflex is in the center of the pupil. So this is pseudo squint. This squint is because please notice this distance. This distance is more than normal. You see this distance between these two eyes is more than normal. So that's why you see pseudo squint. This is because of this fold of skin. This is epicanthus. ये जो skin का fold है, इसके वजह से अपने को ऐसे लग रहा है कि the patient has got convergent squint, but convergent squint नहीं है. This fold of skin is called as epicanthus. So if first we have tested HB reflex, then the next test that we can do is called as cover test. And these cover tests are very easy to understand. They're very interesting. So I will discuss it twice. So you'll be able to understand. So what do we do in cover test basically? In cover test, we just make the patient's eye fix on a torchlight and see whether there is any movement of the eye or not. And on the basis of this, we can say that whether the patient has got squint or the patient doesn't have squint. So first thing that we do is called as cover test. Remember friends, cover test is done to detect and confirm tropia, means manifest squint. There are two types of squints basically. One is called as manifest. Manifest मतलब आपको हमेशा दिखता है. That is called as tropia, and other is called as latent squint. Latent squint कभी-कभी दिखता है. So what do we in this manifest squint? We know that the patient's right eye here is squinting eye. So what I am going to do is I am going to cover this eye. What I am going to do is I cover the normal eye. So I put a cover, I cover the normal eye with the hand and ask the patient to fixate with the right eye. We can give again a fixation target like torch or a pen or any bright colored object. So this eye will move towards right to take the fixation. So this is, if you observe whether this eye moves or not. If this eye moves, then that confirms our diagnosis that the patient is having tropia or squint. So the patient's eye looks inward here. So this is esodiviation or esotropia or convergent squint. And when I'm covering the normal eye, then this eye is moving towards the right to take the fixation. So that confirms our diagnosis. So this is cover test. So what we have learned from the cover test, that we are putting cover on the patient's normal eye and we are observing the movement of the squinting eye. So if the squinting eye moves, then our diagnosis of the squint is confirmed. So what is the mechanism of this? What does covering one eye do? Covering one eye will, what happens when I am covering this eye? What happens when I cover the eye? Then it interrupts the fusion, and then the patient takes fixation. So that is called as cover test. So I hope we have understood the cover test. Then we have to do cover uncover test. So cover uncover test किसमें करने का है? फोरिया में करने का और latent squint में करने का है. So patients, how do the patients with latent squint come to you? Patient will say that I am having eye strain, eye watering, I cannot read for long times, and sometimes my parents observe that my eye deviates when I am excessively working or when I am under stress. So this is a typical presentation of latent squint or called as phoria. So what do we do in phoria? What do we do? In phoria, there is no squint apparently. Both eyes are looking straight. So what I do is I cover one eye. So when I cover one eye, what happens? The fusion is broken. The impulse, binocularity is a very strong impulse, friend, because the patient wants to see with both eyes. Patient wants to have binocular vision. Fixation is maintained and there is no squint in latent squint. But when I'm covering one eye, then that eye under cover moves. Then the eye under cover moves and goes into its squinting position. And when I remove the cover, I check that there is again the movements towards center. So this test will confirm the presence of phoria. So what do we do is we observe the cover eye. What we do is we cover one, we make the patient fixate on an object with both eyes. Then we cover one eye and we observe the covered eye when we remove the cover. So when we remove the cover, when we uncover the eye, then the covered eye will deviate to take the fixation, and that is how we diagnose cover. That is how we diagnose phoria. So alternate cover test. What do we do is here we want to see whether which eye is dominant. So patient is already giving history of squint and patient says like मेरे दोनों eyes deviate होते हैं. So what we do is we cover both eyes alternately and we observe the movement of the eyes and the fixation of the eye. For example, if the right eye is dominant, then the right eye will take fixation more readily and the fixation will be maintained for more duration in the right eye as compared to the left eye. So this is called as alternate cover test. And the other importance of this alternate cover test is to see whether the primary deviation is more equal to secondary deviation. This topic is complicated and it is important in paralytic squint. Paralytics in normal squints, in concomitant squints, what happens that the deviation of both eyes will be normal, will be same. But in paralytic squint, the deviation of the normal eye will be more than the deviation of the squinting eye or the paralytic eye. So this is called as secondary deviation more than primary deviation. So that test is done to diagnose paralytic squint. So just it's a slightly complicated topic, but I just want to mention. So in slide number 1, we have covered the left eye, okay, and then we are uncovering the left eye. So left eye kya karega? It will be squinted and again it will take fixation, right? So we'll observe the amount of deviation, amount of movement here. So this is primary deviation. Then I am covering the right eye, and when I remove the cover from the right eye, again there will be some deviation. So this deviation is secondary deviation. So these primary and secondary deviations will be same in concomitant squint, whereas they will be different in paralytics. Lastly, right now, cover test and Hirschberg test or HB reflex test were done to diagnose the squint. So if you want to quantify the squint, we have to use a test called as prism cover test. What do we in prism cover test? We perform the same test, friends, cover and cover test or alternate cover test, but the difference here is that we put prism in front of the patient's eyes, and the apex of the prism should be towards deviations. For example, if the patient is having right eye convergent squint, then the apex would be towards the right side. So this is what we do. We what we do is we put prisms of increasing strength with apex towards deviation, and we do cover and uncover test till there is no movement of the eye under cover. So that will give us the, and we check the amount of prism or the diopter of prism which was required to stop this movement. So this will be the amount of squint. So this is the prism bar cover test. So this is cover uncover test. So let me just try to see. Now here the right eye we have put a cover. So observe carefully what has happened to the right eye. Oh, sorry. So I am covering the right eye. So there is nothing. Unfortunately, I'm not able to explain you here. See here, I think this. Yeah, when I am covering the right eye, see there is a movement of right eye, and the right eye is taking fixation again. So this is alternate cover test. I hope you are able to see that. Now let us try to see the cover uncover test. Yeah, see that there is a movement of right eye when it is under cover. So this is cover uncover test to diagnose phobias. Let me try to. Okay. So this is prism bar cover test, in which what we do is we use the prism to quantitate the deviation. We change the prism power until the movement is neutralized and use this number to plan surgery. Yeah. So there are many tests which can be done to further evaluate the squint. So these tests were enumerated in the slide before. This synaptophore, there is an instrument called as synaptophore on which we can do multiple tests. Then diplopia charting is done to is done to see whether the patient is having any diplopia or not. Then we can do tests for binocular vision, vergences, and so many tests we can do. In this force duction test is done to see whether there is any entrapment of the muscle. Okay, so these are the various tests that we do in squint. So the last and most important thing is, what do we do for the squint? What are the treatment options for the squint? So first thing that we should see is whether there is any amblyopia or not. If there is any presence of amblyopia, then we have to treat that amblyopia first by occluding the normal eye. For example, if vision in right eye is normal and if the vision in left eye is less, then we occlude the right eye with the help of occluder till the time that the left eye vision becomes normal, and then we do further treatment. So पहले अपने को amblyopia treat करने का है. We have to first treat the amblyopia, and the treatment of amblyopia is occlusion of the eye. Occlusion मतलब आँख पूरा बंद नहीं करने का. We occlude with the help of pad, and this occlusion can be for full day or it can be for partial time of day. There are various types of occlusion. This is called as full time occlusion and part time occlusion. So right eye में vision कम है, right eye is squinting, then we occlude the left eye for say 5 days in a week in a 6-year-old child. If the child is say 4-year-old, then we occlude the right eye, the left eye for 4 days and the right eye for 2 days. There is a formula for that. So we occlude the normal eye and we stimulate the amblyopia eye. So that is the cornerstone of treatment for amblyopia. That is called as occlusion treatment. So we first do occlusion. We have to check the refractive error. That was the part that was missing. That was not highlighted in our discussion. So we have to do a full cycloplegic refraction. We have to paralyze the ciliary muscle by using atropine or hometropine, depending upon the age of the patient. Then we do cycloplegic refraction and we have to give the correction to the patient. So that is the first thing. We have to glasses. In convergent squint, usually you find that the child is hypermetropic. So in divergence squint, there might be presence of myopia. So we first correct the refractive error and then observe the patient if his squint is improving or not. If his squint improves with the glasses, then we don't need to do further treatment. But if it doesn't improve, or if the patient doesn't have refractive error, then we have to do surgery. So basically, the funda of surgery is either we strengthen the strong muscle, the weak muscle, or weaken the strong muscle. If the patient has got convergent squint, if the medial rectus is strong, the medial rectus may be strong and the lateral rectus may be weak. So we have to do resection, means resection of lateral rectus and recession of medial rectus. So what do we do in recession of any muscle? We just disinsert that muscle from its insertion and move the insertion back. So we recess the muscle. In what do we do in resection? We just cut a portion of muscle and suture it back. So that is called as resection. So resection makes the muscle stronger and recession makes the muscle weaker. So we do surgery. There are other muscle surgeries also like transposition and all, but for the sake of simplicity, just focus on resection and recession. Then in temporary squints like paralytic squints, we can give prism glasses. Okay, and sometimes we need to, in latent squints, we just want to give muscle exercises to the patient rather than operating. So we can use synaptophore or we can use prism to give exercises. So that is all about treatment of squint, friends. It's a very vast topic, but I hope you have understood how do we diagnose squint. I hope we have understood what is how do we do CHB reflex and how do we do cover tests. So if you have any doubts, please don't hesitate to contact me. Thank you so much.